Hi, everybody. This is Dr. Tonya Cremin. I'm so sorry that our third meeting didn't work out, but I wanted to give you an opportunity to learn about all the things I had to share with you. So I'm going to record this and send it to the library so that Luca can send it out to you all. Let's see if I can share my screen this way. Okay. So this is Living Your Best Life During Menopause and Beyond, Part 3. And these are some important things I want you to consider for your overall health. So in today's session, the third session, we'll talk about some general preventive care in the perimenopausal and menopausal period, prevention and screenings for general health concerns, including cancers, diabetes, hypertension, and hyperlipidemia, which are high blood pressure or high cholesterol. So, the number one thing I want to talk to you all about today is cardiovascular disease, which is really overlooked oftentimes in women in particular. It's not thought by the general public that women are impacted that much by cardiovascular disease, but in fact, it is the number one killer of women in the United States, and 1 out of 3 women will die of heart disease. More women die of heart disease, cardiovascular disease than men because it's not usually recognized. And just as in men, it increases with age, but the increase starts a little later in women, often after menopause in general. Most people have issues with cholesterol levels increasing in the earlier years after menopause. And if women have premature menopause, it can increase the risk for cardiovascular disease, partly because of that lack of anti-inflammatory benefit from estrogen that we have prior to menopause, and also because of that increase in weight gain that we see and the increase in cholesterol levels. So risk factors for CVD are the same as for heart disease, our ethnicity, family history. Those can't be changed, of course, right? But we can modify other risk factors, and I'm going to go through all of these. So one of the modifiable risk factors, and probably the most important one, is smoking. It's the single most important preventable risk factor for cardiovascular disease in women. Women who smoke are between 2 and 6 times as likely to have a heart attack than women who don't smoke. And if you do smoke and you quit smoking, no matter how long or how much you did smoke, your risk of heart disease drops almost immediately. So if you are smoking currently, I highly recommend stopping. And if you need help, there are lots of ways that you can get help. Just talk to your primary care physician or look online at the American Heart Association. They have lots of resources there. So blood pressure is another big risk factor for cardiovascular disease. A lot of people don't think it's a big deal because you don't often feel anything when your blood pressure is high. But it is doing damage constantly to the small blood vessels in your body when you have high blood pressure that hasn't been controlled, either with diet and lifestyle changes or medication. The number that you want to have on a blood pressure monitor is generally below 120 over 80. Lots of people will say, but I feel fine when it's 140 over 90. You might feel fine now, but it is doing damage even though you don't know it. Um, so any level over 130 over 80, then that is considered high blood pressure. Between 120 and 130 and the systolic, between 80 to 90 for the diastolic are considered pre-hypertension. And of course, we want treatment. Usually, we can do a 3-month trial of diet and exercise, depending on how high your blood pressure is. If it's above 150 over 90, I probably wouldn't go for that kind of trial. But because a lot of times by the time people walk in the door to their doctor, it's been that way for a long time. However, if it is below those numbers, then a trial of diet and lifestyle changes, especially reducing sodium intake, can make a big difference. High cholesterol is another risk factor for heart disease. These high levels build up plaques in your blood vessels, which thicken and shrink the blood vessels, and they can even shed and cause blockages when you have a blockage like that, that causes a heart attack or a stroke. Uh, Diabetes is another very important risk factor for heart disease. And people who have diabetes are significantly more likely to develop heart disease than people without diabetes. Managing or preventing your diabetes by losing weight and watching your diet can be really important. So some symptoms of diabetes are here: increasing thirst, wounds that don't heal well, feeling tired all the time, even if you get a good night's sleep, your vision blurring, frequent urination, and unexplained weight loss. By the time you have unexplained weight loss, your sugars are probably very, very high. So if you have any of these symptoms, get in to see your doctor so that you can be screened for diabetes. So lots of people will say that sitting is like the new smoking. A sedentary lifestyle is absolutely a risk factor for heart disease. And so regular physical activity, especially aerobic exercise where you get your heart rate up a little bit, can improve your cardiovascular health. So the amount of activity that you need is at least 150 minutes per week of moderate exercise like brisk walking, or 75 minutes per week of vigorous exercise. So moderate exercise, what we really aim for would be enough activity so you can't sing comfortably, but you can talk comfortably with a friend. So taking a quick walk with a friend during lunch or after dinner, or with your dog or your family, can be a great way to get that exercise in during the course of your week. And it has been shown that women in midlife who exercise regularly tend to have lower weights, lower blood pressure, lower blood sugar levels, as well as better cholesterol levels as well. So weight overall is by itself a risk factor for cardiovascular disease. In particular, it's been shown that women who have a waist measurement 35 inches and above have an increased risk for cardiovascular disease. For men, it's a different number. So women who are overweight can improve your health quite a bit just by losing 10% of your weight. So for example, if you weigh 200 pounds, just losing 20 pounds can make a big difference in your overall health. And that will play a role with everything from cardiovascular disease risk, blood pressure risk, diabetes risk, and cholesterol risk. A combined approach of diet and exercise is best. Poor nutrition by itself, even if you have normal blood pressure, normal cholesterol levels, normal blood sugar levels, if you have a poor diet, uh, then that increases your risk of heart disease as well. So diets that are high in saturated fat, like from animal fats, um, meat, fatty meats, things like that, burgers, red meat, uh, chicken skin, can increase the saturated fat in your diet. And that plays a role in building up cholesterol in your bloodstream and those plaques that I mentioned before. High sodium or salt in your diet, especially in processed foods, can play a big role in your cardiovascular disease risk too. So you want to choose a diet, and I'm sure Jessica is talking about this in her talk as well. High in fruits and vegetables with a wide variety, as well as whole grains and high fiber. Cold water fish, which is salmon or tuna, mackerel, sardines, anchovies. Those things are excellent for your cardiovascular health. And other proteins that are low in saturated fat, like the white meat on chicken, or plant-based proteins as well, such as tofu. You want to reduce your sodium intake, reduce your alcohol consumption, and a great resource for a healthy diet is the DASH diet, which you can just look up online. DASH stands for Dietary Approaches to Stopping Hypertension. It's actually sanctioned by the National Institutes of Health. It's been around for a long time. It doesn't get talked about nearly enough, but it's a great resource. And if you can download a PDF for free of the DASH diet, and it has recipes that are available. There's a lot of good information out there about the DASH diet. So aspirin, will aspirin prevent you from having a heart attack? The data is really mixed. It's commonly recommended for women who have already had a heart attack or stroke, or who have known cardiovascular disease. But the benefits haven't really been shown clearly to outweigh the risks of gastrointestinal bleeding in your stomach and your intestinal tract. in women who have not yet had a diagnosis of cardiovascular disease or heart attack or stroke. So you don't want to begin aspirin therapy without talking to your physician first. So CVD and premature menopause, as I mentioned before, premature menopause might increase someone's risk for heart disease, and that's for all the reasons I discussed earlier. So you absolutely want to follow a heart healthy lifestyle and stay up to date with all of your routine screenings for cholesterol, blood pressure, and diabetes. If you don't have any issues, you want to do those annually and more frequently if your doctor recommends. And then, of course, if you are recommended to take medication for any of these conditions, please do, because they may help save your life. All right, cancer. Everyone's worried about cancer. Women do have a 1 in 3 chance of developing any type of cancer, from skin cancer to breast cancer to colon cancer and all of the other cancers you've probably heard about, and many you probably haven't at any time in their lives. Menopause doesn't increase cancer risk by itself, but of course, as we age, many more cancers are more likely just because we have our bodies are older. There are, again, modifiable and non-modifiable risk factors for most types of cancer. So the non-modifiable risks that I mentioned before are risk factors that we don't have any control over. So those include age, ethnic background, and family history. Modifiable risks include things that we do have at least some control over, such as obesity, alcohol consumption, exercise, nutrition, smoking. And you want to educate yourself, be aware of more common cancer signs and symptoms. I go through a few of these later on. And stay up to date with your recommended routine screenings, which may help any cancer be diagnosed at an early stage when they're most curable. Breast cancer, which is the most common cancer diagnosed in women in midlife. It's 1 in 8 in the course of your lifetime. So more and more women survive and thrive after breast cancer because we can detect it so much earlier with mammograms and other types of diagnosis. So because of advances in mammography, we can see less advanced cancers much, much earlier than ever before. And I want to reassure you that the amount of radiation that you get in a mammogram is far less than the background radiation in walking through an airport. They really brought down that dose of radiation so much. I know some people are worried about that, but I really have no concerns over that. So, breast self-exam, maybe the jury is kind of out on that. You absolutely, if you notice any changes in your breast, you want to talk about that with your doctor, have them examine you and send you for follow-up screening if necessary. Mammogram, as I mentioned, is the gold standard to screening, and in Connecticut, standard of care to start screening it is age 40. But there are some mixed recommendations from some of the professional societies. Anywhere between 40 and 50 is typically the normal age to start, and is suggested annually to every other year. Endometrial cancer or uterine cancer is cancer of the lining of the uterus. This is a picture. I want to just go over a little bit of anatomy here for everybody. So this is the reproductive organs of the female or women. So if we could remove your skin and your abdominal wall inside your body, you would have the vagina. So this area here would be the outside of the vaginal area. And then this area here is called the vaginal vault. This is a cervix. If you could look at it from the bottom up, it actually, so when we do a pap smear, we insert the speculum here into the vagina, and we actually see the cervix. So we're examining all of the tissues, the mucosal lining, we call it, of the vagina, and we're examining this part of the cervix here. That's as far as we can see. And it really looks like a little pink bagel at the top of your vagina. So to do any other studies in depth of any of the rest of the reproductive organs, we would have to do ultrasounds or sometimes MRIs or CAT scans, or sometimes we do studies where we inject fluid so we can see what lights up and can kind of help us see if all of these areas are open and flowing or if there's anything we need to be concerned about. So ovaries here, the uterus here. This is the area that builds up the lining with blood before a period, which sheds during a period, right? And then when we go through menopause, this lining stops building up because the ovaries aren't producing estrogen to cause this lining to thicken any longer. And these here, that look like little hands, are called fallopian tubes. So that's just when the ovary releases an egg every month. These actually aren't really attached. They're kind of a little bit separated. So it floats out into the air, gets vacuumed up by the fallopian tube, and then travels down and uh, inserts itself, uh, what floats around in the uterus actually, unless it's been fertilized, and then it will implant itself someplace in the uterine lining for a developing pregnancy if it gets fertilized. So at any rate, I just wanted you to all have that information before we go on. So for endometrial cancer, family history does play a role here for some women. Previous pregnancies and a history of using oral contraceptives can provide a little bit of protection. The most common symptom is abnormal uterine bleeding. So if you do have bleeding that's kind of random and doesn't seem to make sense, please go talk to your doctor about it. We don't really have a screening test for endometrial cancer, although sometimes pap smears can show some abnormal cells that can indicate endometrial cancer. Testing would be if we had a suspicion that a woman had endometrial cancer because maybe she has abnormal uterine bleeding, we would absolutely do an endometrial biopsy and probably a transvaginal ultrasound. Or sometime, as I mentioned, we use other types of studies, including hysteroscopy or sonohysteroscopy, hysterography, in order to study and see what's happening internally a little bit better. So standard therapy for endometrial cancer once it's been diagnosed is surgery, which would include a hysterectomy. So cancer, why is obesity a risk factor for breast and endometrial cancer after menopause? It's because fat storage cells produce estrogen, and the more fat cells you have, the more estrogen you produce, even after menopause. Increased estrogen increases risk of breast cancer. And after menopause, your body isn't producing progesterone anymore to offset the estrogen. So, as we know, as we learned a while back, estrogen without progesterone increases risk for endometrial cancer. And even just being 20 to 50 pounds overweight increases your risk of developing these cancers. And in addition, as we mentioned before, obesity is a risk factor for other types of cancer and for heart disease and diabetes. So it's important to try to keep your weight at a healthy level as much as possible. Cervical cancer. So the reason we do pap smears is to look for cervical cancer. So in a pap smear, what we do is we scrape some of the cells very gently off the cervix to see if they are normal or abnormal. If they're abnormal, then we usually have to do further studies to see if it's actually how advanced it is. We can tell there's a whole spectrum of abnormal cells when it comes to cervical cancer. And from the first abnormality to invasive cervical cancer, it usually takes 20 to 30 years. HPV vaccines have actually helped reduce the risk of cervical cancer. And so it's our first cancer vaccine, actually. So most women who are perimenopausal now did not have an HPV vaccine, but you can talk to your doctor to see if it makes sense for you to have it now. And I'll talk about that a little bit more later. So, menopause itself does not increase the risk of cervical cancer, but HPV, I didn't mention, but I do have it here on the slide, is human papillomavirus. So, cervical cancer is really sexually transmitted. So, if you have an HPV infection that goes unabated, untreated, it can lead to cervical cancer decades later. So sometimes now we do swabs as well to just detect if HPV is present, and if it is, then we treat for that. So increased sexual number of sexual partners or many, many years of sexual activity can increase the risk just because of the exposure to the HPV. Early stage cervical cancer doesn't usually have any symptoms. So just because you feel fine doesn't mean you don't have it, which means that it's important to get those pap smears done. Late stage symptoms include abnormal bleeding and spotting and abnormal vaginal discharge. The death rate of cervical cancer has dropped significantly in the US and Canada because of early detection and treatment. So please go and make sure you're getting those routine tests. If it's diagnosed early, it's absolutely curable. And yeah, so that's it. So the HPV vaccine, should you receive an HPV vaccine to prevent cervical cancer? It's a good discussion to have with your healthcare professional. It's usually recommended for ages 9 to 26, but it's approved for adults up to age 45. And it depends on someone's individual risk. If you're in a long-term monogamous relationship, you probably don't need this vaccination because your risk of a new HPV infection is low. But women under 45 who have or anticipate having new sexual partners who are in a non-monogamous relationship might benefit from vaccines. In addition, condom use is really important to help prevent the chance of getting this virus or another sexually transmitted infection. Okay. Ovarian cancer. So again, unfortunately, we don't have any reliable screening test. It's usually advanced when symptoms occur, unfortunately. And symptoms include bloating, diarrhea that doesn't make any sense to you, abdominal pain, fatigue, feeling full early. Less than 25% of cases are diagnosed in the early stages, and the risk increases with age. The highest risk is in women who have a family history of breast or ovarian cancer. And in that case, it's worth talking to your doctor to see if genetic testing is appropriate for you. It's not appropriate for everyone, but for some it is. So there are some hereditary syndromes that can increase risk, such as Lynch syndrome. And fertility treatments, there's there's some controversy about whether or not fertility treatments can increase the risk of ovarian cancer. It's really not clear. So protective factors include having had any full-term pregnancy, breastfeeding, past use of birth control pills, or bilateral tubal ligation. So if your fallopian tubes that I mentioned before, these here, have been surgically closed or tied off. Sometimes we call it a tubal ligation, as I said, or having your tubes tied. Okay. Lung cancer. More people die of lung cancer than colon, breast, and prostate cancers combined. So this is men and women. The most common symptoms are chronic cough, fatigue, weight loss, shortness of breath, and the biggest risk factor is tobacco smoking. Other risk factors include genetics, previous radiation therapy to the chest, maybe for Hodgkin's lymphoma, for instance, or secondhand smoke, living with somebody who smokes, even if you lived with them when you were a child, it can increase your risk later on. Air pollution, asbestos exposure. So if you have a home or work in a building that has exposed asbestos, that can increase the risk for lung cancer. And then radon. Here in Connecticut, we have such a large rock mantle that that reduce that emits radon gas. And so if you haven't had your home tested for radon, it's definitely something you should consider. And it does cost a little bit of money to have remediation put in place, but it's a really important thing to do to lessen your risk from the radon exposure. So stopping smoking has the best effect to reduce your lung cancer risk up to 90%. So if people are smokers, if they had a 20-year pack history of smoking, so that means smoking one pack a day for 20 years, or it could be two packs a day for 10 years, or a half a pack a day for 40 years. Or people who currently smoke and have quit within the, or have, excuse me, who have quit within the past 15 years. You can have screening with low dose CAT scans if you're between the ages of 50 and 80, and those should be covered by insurance to see if you have lung cancer. So definitely another thing to talk about with your doctor. Colon and rectal cancer or colorectal cancer, a little bit more anatomy here. It's the third most commonly diagnosed cancer in the US and the third leading cause of cancer death in United States women. One out of every 25 Americans is expected to develop colon cancer at some time in their lifetimes, and most in their 60s. And the most common symptom is black or tarry stools, changes in what your stools look like. If they've been normal for a time, then all of a sudden they start to change, but you haven't changed your diet, something to consider. Or if you have unexplained weight loss, definitely go talk to your doctor. Risk factors, again, family history, and some of those inherited syndromes that increase polyps in the colon, which the polyps then do develop into cancer. So non-modifiable risk factors here would include ethnicity, uh, age over 50, just like any cancer, and a personal history of inflammatory bowel disease like Crohn's disease or ulcerative colitis. So modifiable risk factors are stopping smoking, exercising regularly, and eating a healthy diet, especially one low in saturated fat and limited intake of red and processed meats. So processed meats would be deli meats like deli ham, deli turkey, things like that, bologna, etc. So screening colonoscopy is the gold standard. And the beauty of a colonoscopy is that if they find the polyps, they can remove them and in that way prevent them developing into cancer. So if you do choose to do alternate testing using fecal tests like Cologuard or annual stool test at your physician's office, if there's an abnormality found, you still have to go for a colonoscopy so that they can see what's going on. Skin cancer. So basal cell and squamous cell cancers, carcinoma, are absolutely the most common, and they have pretty high cure rates. If you notice any abnormal lesions on your skin, you should have them go looked at. Melanoma is much less common, but far more deadly. And these are the A, B, C, D, E's of melanoma. So we look for asymmetry of a lesion. So the ones on the left here would be considered normal, and the ones on the right here would be considered worrisome. So the borders, the B, if the edges are smooth, it's probably fine. If they're irregular, then that definitely wants to be looked at. This isn't a great picture here. I don't know if it's showing up well for you all, but if the color is even, there's a good chance it's fine, but not necessarily. You don't want to assume that. But if the mole has multiple different colors in it, you definitely want to have that looked at. Or if it's very dark, you see these lesions here are very dark. The diameter plays a role. So if it's less than a quarter of an inch or great, it's probably fine. If it's greater than a quarter of an inch, then can be concerning. So, and what we look for is one easy way to look at it is the size of a pencil eraser. So if it's smaller than an eraser head, then it's probably okay. If it's bigger than an eraser head, then you want to have it looked at. And evolving. So if it's changing, if you have a mole, even if it's been there a long time and it starts to change, or if you have new moles that show up, you want to have those looked at as well. So the risk factor for all cancers is sun exposure for all of them. Skin cancers, that is. So particularly blistering sunburns and use of tanning beds, fair skin, difficulty tanning, family history of skin cancer, and having a significant number of moles increases your risk for skin cancer. So you want to use sunscreen even when you're out and about in the normal course of your day. Just those little bits of sun exposure can increase your risk. So wearing wide-brimmed hats, nice cute floppy hats can be good, and just wearing sunscreen every day, even in the wintertime. So women who have a personal or family history of any type of skin cancer should absolutely have an annual full body scan with a licensed dermatologist. And possibly more frequently if they suggest that. And as I mentioned before, any new bumps on your skin or different colored moles, anything that you're concerned about, you should go see your primary care doctor or dermatologist. Okay, immunizations. So I am a strong advocate of vaccines. They have prevented more than 29 million hospitalizations and 1 million deaths for US children just in the last 25 years. But there's so much vaccine misinformation out there. Vaccines have been studied for decades and decades. The one of the number one reasons that the world population has increased so much is because of vaccinations eliminating or significantly reducing childhood diseases and other diseases that may have killed people decades prior. So you're never too old to get vaccinated. Ask your physician if you've had every vaccination that you need. And this wouldn't be a naturopath or a chiropractor. This would be an MD or a DO or a nurse practitioner can also tell you if you've had all the vaccines that are appropriate for you and your age and your current medical situation. So, vaccines work by imitating an infection to engage your body's natural defenses. I tell my patients it's like soldier training. So, the vaccines teach your body how to recognize the enemy, the infecting agent that could make you sick. They don't cause an infection. Most vaccines are dead viruses or, in certain cases, bacteria. So, they cannot replicate at all. They can't reproduce themselves in your system at all. The reason people might feel a little bit sick after they get an immunization is because your immune system is saying, hey, I see something that doesn't belong here. And it's training your body. So that means your immune system is working to build antibodies to recognize the virus or bacterium in the future so that it's ready to go when it shows up in the wild, if you will. So then your body stores a memory of the infecting agent, and if it encounters it, it can rev up the masses of immune cells to fight it off more quickly. So you don't get sick at all sometimes, like with measles, or you don't get as sick as you might be, such as with the flu or COVID, if you didn't have the vaccine. So I'm going to go briefly through recommended immunizations for adults, and these recommendations assume a full panel of routine childhood vaccines, including the common vaccines below, which were given to children born before 2000. And those include measles, mumps, rubella, diphtheria, pertussis, and polio. So if you were born before the 1950s, most of these were not around at all. So you may require additional measles vaccination. You may have seen that in the news with some of the outbreaks in unimmunized populations around the country. If you were born in 1957 or before, you probably had measles, so it's probably a non-issue, but you can have your doctor run a test if you're concerned that you didn't have it to see if you're immune. And if you were born after 1957, then there are um, in different times throughout history, there were different efficacies of the vaccine. And so some people may require a booster and some people may not. Okay, so this chart is tough. You can find it on immunize.org and hopefully on the CDC website. But these are generally the ones with the red arrow next to them are generally recommended for most people. And if you go across here, you'll see the age of recommendation because sometimes the age varies and you can get a little bit of more detailed information. So generally speaking, COVID vaccines and flu vaccines are recommended for everyone from 6 months and up, unless they've had significant serious adverse reactions, such as Guillain-Barré syndrome, for instance, to one of those vaccines. RSV is indicated for people over 75. RSV is a respiratory virus. It's a terrible bad cold that causes a lot of wheezing, but it can be deadly in infants. So we definitely give infants RSV vaccines. And now we have it available for people over 75 too. Excuse me. Tetanus, you've probably all heard of tetanus shots, needing a tetanus shot every 10 years. They're usually combined with tetanus and diphtheria, and then oftentimes in younger people, pertussis. So, tetanus is lockjaw, you may have heard of. So, that involves exposure to the classic rusty nail, but tetanus is everywhere in the environment. It can cause paralysis of the respiratory muscles, and it can kill you. So, in all of these cases, it's far better to prevent these illnesses with vaccines than it is to try to chase them and get you feeling better if you've gotten these illnesses. Diphtheria and pertussis are both respiratory viruses that can make you very sick. Pertussis, we don't really see diphtheria around here anymore because so many people are vaccinated against it. And that's also the case with some of these other vaccines I'll talk about in a second. Pertussis is whooping cough. The cough from whooping cough can last 3 to 4 months. Even if we give you antibiotics, it still can last 3 to 4 months. So it's far easier to prevent it than to end up with it. And in fact, we are vaccinating adults, all children who get vaccinated appropriately end up with the pertussis vaccines and boosters, but a lot of adults don't never had it or may need boosters. For instance, anytime they have a new baby in the family, you want to be vaccinated against pertussis if you're going to be taking care of that baby on a regular basis. So measles, mumps, and rubella are viruses that we don't see too much anymore. Rubella is also known as German measles. Mumps causes swelling of the parotid glands called parotitis. Can make you look like you have big chipmunk cheeks. But all of these have other um, complications that can, in some instances, be deadly. For instance, with measles, if you end up with measles, you can have measles encephalopathy, which causes swelling in your brain and can cause death. If you never had chicken pox, um, then, so for instance, if you were born after 1980, you may need to get a varicella vaccine. Zoster is the same virus that causes varicella. So for those of us who did have varicella or chickenpox when we were younger, that virus lives in the spinal cord for the rest of your life. And so, what can happen is it usually lays dormant, but under times of great stress, either emotional or physical, people can have a reactivation of the virus, which causes a shingles outbreak, which is an incredibly painful rash on the skin, which can be found anywhere in the body. It tends to recur in the same place every time it comes back. It can come back over and over and over again. And if that's not treated in enough time with antiviral medication, when you have a shingles outbreak, it can cause something called trigeminal neuralgia or tic douloureux, some people might have heard of, especially on the face, can cause this incredible pain that just keeps coming back over and over and over again. And there's really not good treatments for it. So having your shingles vaccines, 2 doses, if you are over 50, is highly recommended. HPV, we talked about earlier. Pneumococcal is pneumonia vaccine for certain kinds of bacterial pneumonia, and that's appropriate for pretty much everyone 50 and up. It might be appropriate for you if you're under 50, if you have respiratory conditions such as asthma. Hepatitis A oftentimes is a type of foodborne hepatitis that can occur just it's passed from sick person to other people, oftentimes when they're preparing food. So if you're traveling to other countries around the world, oftentimes that's recommended. Hepatitis B is recommended for most people up to the mid 60s. That is a bloodborne type of hepatitis virus that can develop into cancer. of the liver. And so definitely something that we don't want to deal with. And then polio is a common vaccine. So many of us who were older had polio vaccines when we were younger, and we probably don't need it. But if you emigrated here from another country, it might be something important to try and talk to your physician about and see if it's appropriate for you. So that's it. So I hope this has been helpful for all of you. If you have any questions, please feel free to reach out through my website. You can send me an email or talk to Luca, and I wish you all well. Bye.